Welcome to PostNTrac's webinar, Reducing Costs by Automating the Prior Authorization Process. My name is Andrew McFarland. I am a marketing specialist at PostNTrac, and today I will be your host. Joining us as today's featured speaker will be David Barth, PostNTrac Senior Director. Hello, David.
Hi, good afternoon.
Before beginning today's presentation, I want to quickly get a few house cleaning items out of the way. All callers on the line today will be muted so as not to disturb anyone else's listening experience. If you would like to ask a question during the webinar, please type it into the Q&A dialog box in the WebEx discussion panel. We will answer as many questions as possible at the end of the session, and if we are unable to answer your question during the time allotted, we will follow up with an email afterward. A video copy of today's webinar will be made available within the next few days, and we will send an email providing a link when it is ready. Before we move on to today's topic, I want to briefly provide you with a little more information about PostNTrac. We are a CAQH Core certified and ENAC accredited healthcare information logistics company who have been growing and achieving success with payers for the past 10 years. PostNTrac has the infrastructure, architecture, and applications to support all the needs of your transaction. We have worked with the largest health plans for the past decade, providing them with proven scalability, extensive subject matter expertise, consistent SLA attainment, and great service. We really pride ourselves on understanding our customers and our users' needs and continually commit to exceeding expectations. PostNTrac's flexible platform is based upon pre-built solutions that are value-driven to deliver results with speed, cost efficiency, and world-class service. As shown by the map on this slide, PostNTrac drives an incredible amount of provider adoption throughout the United States for our customers and partners, which again includes some of the top health plans in the industry. This is highly beneficial to our customers, as the greater your adoption rates, the more economical the usage of the PostNTrac platform becomes for your organization. Let's start by getting a quick understanding of the 278 prior authorization or referral transaction, which we will at some points refer to as prior auth going forward. Simply defined, prior authorization is the process of making sure a service or prescription is covered by a health insurance plan before it can be completed. To do so, a provider requesting medical services for a patient will submit a completed prior authorization request with pertinent medical notes attached, progress notes, laboratory and radiology reports, etc., and wait for the patient's health insurance to respond on whether or not the prescribed treatment or prescription is covered and approved, or more information is needed, or denied with an alternative treatment proposal. A patient may not request an authorization on their own behalf. An example would be a provider requesting authorization for an MRI to see if it is covered before ordering one, because they may find an MRI would not be reimbursed unless an X-ray is taken first, because it is just as effective and less costly in this instance. A referral includes any services that are ordered or managed. They are designed to keep all participants in a patient's care on the same page to ensure the best treatment and to control costs. Specifically, the referral system helps to ensure optimal care at all levels, helps to control costs, make sure that hospital facilities are used effectively, and that timely patient prioritization occurs for those who most need specialist services. An example would be going to your general physician and being referred to an ear doctor for follow-up on an eardrum rupture. It would be the initiating provider's responsibility to begin a protocol of care with documentation, provide a referral form to you, and to communicate with the receiving provider. Once the receiving provider provides their treatment, it would be their job to document that treatment and provide feedback and send back a back referral form. Prior authorization is a part of the managed care process, which is intended to reduce the cost of providing health care and improve the quality of care by preemptively reviewing medical practices and prescriptions to determine if an equally effective yet cost-saving alternative is available for patients. Prior authorization is the only effective pre-service, pre-payment method to prevent unnecessary treatment, overutilization, and misuse. Timely denials prevent inappropriate reimbursement of services and avoid the pay and chase scenario. The added value of the transaction goes beyond simple financial saving efforts, though. For example, the prior authorization transaction, if it is initially processed correctly, prevents post-service denials, re-adjudication of claims, impacts reprocessing rates, eliminates medical review, and avoids recalculation of member liability, significantly streamlining the process and creating a better collaborative one. An automated process allows for faster review of treatments and prescriptions, where, for example, health payers have been able to discover dangerous drug interactions between a new patient prescription and their current medication, reduce exposure to ionizing radiation emitted by unnecessary scans, and they've even reduced overuse of emergency room services. Quicker reviews also lead to quicker responses, meaning faster patient scheduling and treatment, which improves outcomes and satisfaction for all parties. Examples like these are why it is important to remember that the 278 prior authorization transaction serves a good purpose, such as helping to reduce costs, reduce risks, provide alternative options, and create better collaboration between providers and payers. So the transaction serves a good purpose, it just has not been fine-tuned to efficiently drive the intended results for both providers and payers until now. With a January 1st, 2016 ACA mandate deadline approaching, industry leaders such as CAQH and the AMA have published well-known reports that recommend the same answer to optimizing the benefits of the prior auth transaction. The answer is automation, and that is what we will discuss today. But first, let's provide some data to set the scene of the prior authorization process as it is currently experienced. Of the 6 transactions studied in the 2013 U.S. Healthcare Efficiency Index, the prior authorization transaction was the most expensive one for the payers. In 2013, 110 million out of 130 million prior authorization transactions were completed manually between payers and submitting providers, meaning 85% of these transactions were being done manually, using faxes, phones, and a whole lot of paper. The cost to payers to manually process a prior authorization request currently comes in at an estimated $85 to $100 per transaction. On the other side, providers are spending roughly $20 per transaction. Even the naming of the transaction itself is complicated. Prior authorizations are often referred to as pre-certifications, prior approvals, prospective reviews, prior reviews, and predeterminations. Manual processing is obviously very costly, inefficient, and a burden on resources to both sides of the payer-provider equation, contributing to between $23 and $31 billion a year of industry waste. All of these factors sum up to a mutual experience of frustration for both providers and payers alike. The benefits to the healthcare system, and more importantly to the patient, that the 278 transaction provides have become lost in the frustration of the transaction process. Let's quickly break down what this data means. It basically creates the pain points for both sides. For payers, the process is extremely complex and manual, meaning costly utilization of a lot of resources. They have to deal with not only the actual process itself, but now they're in the process of having to make sure it is done in a manner that will be compliant with the ACA mandate and deal with frustrated providers on the other side of the process. Conversely, providers are doing the best they can to provide timely care to patients. While everybody wants to control costs, it is easy to understand their frustration of having their choices scrutinized to do so. Add to that a back-and-forth process that can keep them wondering if they will be reimbursed for providing care, and you can see why providers are frustrated with the manual nature of the payer process. So we currently have a transaction that is designed to save money and improve care, but it's convoluted and expensive and causing friction in the collaboration needed between payers and providers. Administrative simplification is important to payers in controlling costs, but making sure they receive the proper information is key as well. What if I told you that you could significantly reduce the cost of processing your prior authorization request while reducing manual processes between 50 and 90%? Imagine if I told you your organization could have a scalable process that is able to intake multiple formats and standardize the needed information for you, delivering it at the right time to the right person in a meaningful way. You can. And the answer is automation, and that is that kind of impact it can have. In the 2013 U.S. Healthcare Efficiency Index report, Milliman Inc. reported that by fully adopting automated prior authorization processing, payers' costs could see a savings of over $410 million annually, and the healthcare industry as a whole could see savings of almost $2 billion. significantly driving down transaction costs. It's important to remember that those savings only represent the processing of these transactions. Those savings are on top of the healthcare savings of the results actually produced by the transaction. Another example of the automation impact came in a report published in the September 2013 Journal of Managed Care Medicine that showed pairing automated prior authorization with evidence-based guidelines can ensure such tests are only used when necessary, improving patient safety while reducing medical costs by perhaps 40%. One final benefit provided by automation is that it provides greater transparency among all stakeholders through providing more timely access to information. This in turn allows more accurate decisions to be made faster in regards to need and cost, leading to reduced waste and reduced spending. So how do you go about reducing your costs through automating your prior auth transactions? I hand it to you, David.
Thank you. Andrew, great job putting together those numbers. I'm always amazed by the number in billions that always we find in these kind of studies around processes that seems very positive by design, but unfortunately have been implemented the wrong way or find themselves into jeopardy because of the way people are using it. So what I would like to start by doing is come up with this chart that was published by the American Medical Association in 2011, part of a white paper that they wrote about the prior authorization process. And it depicts very simply the convoluted nature of this process and the way it is handled today. So we all know the process either because we work in this industry or because we've experienced it as patients. And it's amazing to me how a doctor cannot obtain immediately a response from my insurance company when I need to go see a specialist. There's always a discussion about, well, we're going to go through the prior authorization process and we'll come back to you and somebody's going to call you to try to schedule an appointment with you. And if you look at it a little further, sometimes they don't even know whether or not they would need one. So there's an entire time lapse between the time where the physician is trying to put you on a path to whatever medical treatment you need and the time it will happen. All of this because of this mostly manual process. And when you think about it, it seems a little weird because there's a lot of other processes in your life that you can relate to that seem as complicated as this. Take the mortgage process, for instance. Today, you can get pre-approved on a mortgage in a few seconds and have offers from many, many banks in a few minutes if you enter just a few information. Today in healthcare, you cannot get pre-approved for a medication or a procedure immediately because there is manual exchange of information. The payer needs to receive the right information. They are then going to work with the medical office to figure out whether or not they can obtain reports, radiology reports, justifications in order to move forward. So what I would like to do today is really take that as a context process and look at 5 areas where we can really make some progress by automation of that particular step. So we are going to look at the first level, which can be surprising to some of you, but you have to understand that the use of electronic message is widespread for some of the HIPAA-defined transactions like eligibility or request and response. But as the 2013 U.S. Healthcare Efficiency Index report reported, when you go into more complex transactions like the prior authorization 278, paper and manual processing is still widely the truth. So we're going to look at how you can really scale and fully enable the exchange of electronic messages between payers and providers. Then we are going to look at automating the request of referral or prior authorization through the use of that particular EDI pipeline we're going to build and some user interfaces that will facilitate that process. The bulk of the time we're going to spend is really around the prior authorization adjudication. And as you'll see, by enabling a rules engine on the solution, we will be able to accelerate, if not completely automate, the adjudication of most of the requests that are coming your way. The fourth point is not really automation, but is to guarantee or secure the fact that all exchange of information, because there will be exchange of information required, can be kept inside this electronic enabled message process by allowing people to attach notes or other documents to an online discussion or an electronic discussion, as opposed to get out of process and use fax or letters to provide the additional information requested. And finally, hopefully, we will be able, and I know we will, to fully complete the authorization process by automating the authorization itself. So let's jump into it and start with the automation of the exchange of messages between payer and provider. During the presentation, I will use the post-on-track platform as an example just to illustrate the kind of solution that you should be looking for. So let's start with enabling electronic data interchange between payer and provider. The post-on-track platform leverages new technologies to enable payer and provider to exchange information in a secure and compliant way, and leveraging simple agnostic ways to connect to one another, as well as a very powerful cloud-based integration engine that will allow transactions to be routed between the submitter and the recipient of the transaction, edited and validated against standards that it needs to embrace, as well as being transformed, if necessary, from a standard to a non-standard format or the other way around. I just want to point out that if you're looking for an EDI platform like this, make sure that it follows and is certified with particularly the various core programs that allow you to make sure that compliance is reached on the platform, as well as the INAC accreditation that will guarantee that the solution is HIPAA compliant and will handle your information securely over the internet in particular. So let me come back a little bit more on the three functionalities in the center of the platform. You want that platform to be able to, of course, edit and validate transactions, and you want this platform to do that extensively, or to be extensible in that way. What it means is that even though in the example we're going to follow, we are going to use only a few of the multiple transactions standards that exist in the HIPAA world, the platform should be able to handle any of them. It should also be able to handle any kind of information. In the past, pre-internet era, I would say there was a logic of building separate pipelines for separate type of information. This is no longer the case. All information can be handled in a bidirectional secure web tunnel type of platform as long as there is an intelligent validation engine on top of it that is able to recognize and make sure that all transactions follow the rules that they are supposed to follow. It's also important to note that that platform will be able to handle those transactions if it has intelligent routing in its core. By intelligent routing, I mean the capability to recognize the transaction, to guarantee and verify the submitter, who is submitting the transaction, the identity of the submitter of the transaction, understand what the transaction is about, unbundle the transaction if they come in bulk, and route any one of them to the appropriate core system or intermediary step, or follow the right orchestration process. A lot of our customers have many different core systems, not only because care management is not the same as claims adjudication, but also because they have acquired companies in their lives that and are still running their systems. So it is important to be able to understand where transactions are going and where they need to come back to. The last point is transformation, and I'll talk about those core systems again. Sometimes they do not handle or cannot process natively standard transactions. They will have to, so we will have to take an ANSI 278 and transform it into a usable format for the core system it is destined to. Same on the other side, some providers cannot create standard transactions, so the platform should be able to accommodate the format they can actually input and transform those inputs into standard transactions for back and forth exchange. So this is really the first step that you have to do, is to enable this platform to onboard as many submitters as you need to, and in a very simple way. We'll come back to how we onboard those submitters in a minute. Before that, I just wanted to mention that for the prior authorization process, the first level of automation will be to enable the eligibility and the referral and prior authorization transactions on the platform. At this point, you will be probably, the rule is not finalized yet, but by doing this, you will comply to the Affordable Care Act mandate by being able to receive and respond and acknowledge receipt of a referral or prior authorization 278 transaction. The reality, though, is that some of your submitters are going to be able to produce such transactions, others are not going to be able. So to fully automate the prior authorization request process, you will have to provide, and we provide on the platform, an option for a user interface that will allow submitters to submit those referrals and prior authorization. First, I would like to go through how do you guarantee the scalability of adoption of such a platform is by making it extremely simple for submitters to enroll. So in the last 10 years, we have developed a series of agnostic options for submitters to connect to the platform. So we handle this through a very simple enrollment process. It takes 5 minutes. Very soon after, the potential enrollee will be contacted by an implementation specialist who will go through the various connection options for the people to start submitting transactions. And this process is a one-off, meaning that for whatever transaction the submitter wants to onboard, he or she will do it only once. Once the communication is established, whatever additional transaction the submitter wants to exchange with the payer does not require any additional enrollment process. It's just a matter of testing the new transaction, and it is enabled. So one of the popular ways that people connect to us is through a desktop tool that we call the Doodad. It's a very simple tool built on Delphi that will deploy on any type of system on the provider side. Its role is really to gather the files that need to be uploaded into the platform for processing, encrypt the files, establish a secure connection with the platform, and exchange the information. It is also a way for submitters to access reports and various tools on our portal to be able to validate their submission, understand where their files are, or access the various user interfaces. Some of them we will go through today. That said, a lot of providers, and mostly the more sophisticated ones, do not want to deploy anything in their system, so they will instead elect another option, which is to connect directly to our platform through a web service, exactly an API that we provide at no cost for any of the submitters, and they will be able to include basically payer functionalities like eligibility, prior authorization, claims, ERA, all those transactions directly in process inside their system. So this web service will be either integrated into the practice management system of the provider, or an Epic system, for instance, or even their homegrown system, to guarantee that users are the most efficient at looking for an eligibility or benefit information or submitting a prior authorization, in order for them not to jump from applications to applications or portal to portal. So this is really designed to extend the payer's functionalities into the provider environment, and that has been proven very efficient, particularly at reducing the number of intermediaries that we've seen proliferating in the last 30 years in the healthcare management business. So once we're all connected, as I said before, for the most sophisticated users, it's basically the bulk of it. You are able now, if you can produce eligibility and prior authorization standard transactions, you are now fully capable of exchanging information with the payer, who will respond with the appropriate transaction, and you will be able to display those transactions into your system. So this is what a transaction looks like. And the reality in the marketplace is that a lot of people cannot produce such transactions, and a lot of people cannot read those transactions either. So one important thing that you may want to consider providing is a readable user interface for providers to submit their requests. In that sense, what you will help doing is for providers not having to look for places or download forms and then fax them. It's directly online in their environment, in their system, because we also provide portal integration, so all of those interfaces can actually be displayed into local intranets or any other portal that the provider would be using, and allow the office managers or billing people to provide the necessary information to submit a prior authorization. So you can note that in that particular case, the user interface will display appropriate policies that you've put together, referrals that the provider has previously submitted, facility type, what the procedure is, the diagnosis code, and other information like this. So that can be easily managed by the provider in order to start submitting referral and prior authorization requests. Once that's done, now you can really scale who is going to automatically submit requests for referral and authorization. So the next step, logical step, is how do I automate the adjudication of those referrals? There is a lot of referrals and prior authorization, that are just following standard policies. And standard policies are best practices in the medical world. A few examples are Milliman Care will provide a series of guides. The American College of Radiology, ACR, will also provide some guides. But you can, as a payer, also have a series of custom guidelines that you want to implement. So the platform should be the host of a rules engine or a policy engine that will be able to, in most of the cases, provide, by following a simple decision tree, or in the case of the platform here, by really being able to understand unstructured data and understand, have a good understanding of how the policy should be applied, to automate a lot of the prior authorization that are coming through it. So once we have enabled this particular environment, let's go back to our example and say we are going to request to send a prior authorization request, and hopefully it will be standard enough to be automated. Let me just pause here for just a second. It is important to understand that what we're trying to do here is to transform a mostly manual process, 85%, as Andrew pointed out, into an exception-based process. The idea is that you can reverse the trend and go to a mostly automated process with exceptions. So knowing that, we have to provide an environment and an avenue for the payer utilization management team to be able to act upon exceptions. So to do so, we provide a user interface for the payer team to be able to look at requests that are coming the way and have been flagged by the engine for whatever reason, and it can be actually reasons that are not medical reasons, but they can be, well, I want to provide different policies for different in-network providers versus out-of-network provider. So all these kind of options that you want to implement are absolutely customizable on the platform, and the utilization management team will use this kind of user interface to pick up on a queue of exceptions and then make a decision. Decide on a response. You can also push a reason for the response. So I just wanted to make clear that it's not. There is still room, and there will always be a room for manual intervention. We just want it to become the exception and not the rule. So if we come back to our request that we were looking at, we're going to pen that request. It's an interesting request, but we will need a little more information. So if we look at the assumption that there is no need for manual process in this particular example, provider office is sending a referral, a prior authorization request through the user interface, and the policy engine rules it as it needs more information to be able to make a decision, or more information to be able to push it in a queue for a case manager to decide on the request. It will immediately send back a pending response asking for that information. So that's where we get to our fourth opportunity of automation, or at least acceleration of the process. The response comes automatically, immediately in real time, so the provider's office people can understand, oh, I need a radiology report and lab results for that prior authorization to move forward. In today's world, in a fully manual process, it would probably take a couple of days for that response to come back, if not several days, for the doctor's office to call back the payers trying to figure out what's going on with my request. And the payers say, oh, you need more information. And then the information would have to be mailed or faxed. Here, what we're going to do is to provide an environment for the provider to actually upload the necessary information in the electronic conversation if you want. So the next, by clicking on upload or add information, the provider will be able to upload a PDF file or add a note to the request. In the background, we enable this by using the ANSI 275 attachment transaction standard to be able to repatriate securely the note or file or the documentation that is being attached to the particular request. Here, a radiology report as a PDF format that we upload in here. So the request, having gone through that process, will now be pended in an exception queue on the provider side, on the payer side for decision. So just to recap, we've been through 4 great opportunities to really automate and/or accelerate the process of prior authorization. What you need to do is, 1, enable EDI transactions to flow simply through leveraging new technology between payers and providers. Avoid intermediaries as much as you can, and make sure that you enable at least those 3 transactions, the eligibility transaction, referral and authorization, and attachment transaction, to be able to full cycle automate the submission of the request through the handling of those transactions or specific user interfaces that you provide to the provider community or the submitter community, as well as a series of a policy engine that enable standard or customized policy. User interface on the payer side to be able to make decisions on exceptions to the automated request, or be able to make decisions that are informed by attachments that are actually provided within that exchange. So by doing all of this, you will be able to actually go to one of the great use cases that I think represents how you can be expedient in providing better service to your provider community. We're going to take an example where the submission occurs, same as before, but the response is the following. It's a denied response, but the engine, with no human intervention, just following the policies that have been set up in the engine, will provide a couple of suggested alternatives to the path that the physician is trying to follow. Here, you have 2 suggestions. The yellowish one at the top is a pending suggestion that says, if you provide proof of pregnancy, we can go ahead and probably authorize that option. The second one is a fully approved, certified in total suggestion that say, if you replace the tomography by an ultrasound, it will be fully approved right away, and you will be able to go ahead and schedule an appointment with your patient immediately. And remember, this is in real time. Real time versus days or weeks of, wait a minute, why is it denied? But we need to move forward. Hey, maybe you can have an alternative. So all those discussions are gone. You just have a real-time response that allows the physician to make a decision and go ahead with what he wants or she wants to do. The last piece, of course, is, okay, so we are going to choose the approved way, but that's the same. You don't want to give this kind of response. So the last piece is really to have the same kind of readable user interface for the authorization. Certified in full with all the necessary information that the provider will be able to use in a claim later when time will come to submit the claim and get paid. And remember, we went from days and weeks into a few minutes, and two things happen. One, the patient can be treated. Two, the payer is guaranteed to be paid for the decision he is making for his or her patient. So I'd like to recap a little bit what you need to look at when looking for a solution to automate the prior authorization process. The idea is really to automate referrals and prior authorization requests and go from a fully manual or 85% manual process into an exception process where the manual reviews are few and really the bulk of the process is fully automated. We think by doing this, there should be right away 30 to 40% reduction in cost in managing the prior authorization process. And that's from a payer perspective. It is pretty much obvious that there will be also great benefits on the provider side, one of which is that the frustration is probably going to be going away pretty fast. And so the service level that the payers are going to provide to the provider community will be much greater for this. One piece that we find also that has to be very important is the capabilities to add attachment to pending requests, because the danger of not doing this will be to automate a piece of the process, and then the moment you need more information, which should occur a lot, you are going to go off process and into the fax and mail world again, and that's where all the potential savings are going to be lost. I want to make a particular point at saying that medical policies should be extremely flexible in the engine, should be able to have standards one, custom ones, and the customization should not be just for the policies. It also should be around who the policies apply and how they apply, because the reality of the world is that you really want to be able to manage the relationship with the provider community as best as possible. And in order to, it is obvious that you will have to adapt the policies depending on the relationship you have with the provider community and with the submitters and the various environments. Finally, the solution needs to be turnkey, and when we say turnkey, it really means it should be extensible to do other things. EDI is really a specialty, and at Post-on-Track, it is something that we've done for 10 years and we are extremely good at, is to exchange information, EDI in a sense of data interchange, manage data and exchange data, whatever it is and wherever it comes from and wherever it has to go to. The important thing is to make sure that it comes from the right person, it's in the right format, it arrives at the right time, to the right recipient, and in a secure way. You need to be able to integrate into vendors and in different environments, because particularly in the prior authorization world, sometimes you will have delegated management, And so you will have to be able to integrate with those third-party vendors and integrate them into the process. And finally, it is important that you meet the submitter community where they are in terms of technology. So you need to provide various ways for them to connect to you, as well as various user interface options, being fully developed user interface or integration options into portals or other means for the user community to really find it easy to do business with you. With that, I would like to thank you. And Andrew, I think we have a little bit of time for some questions.
We do. Thank you very much, David. That was very informative. I hope everybody found it beneficial. If you have any questions, feel free to type them into the Q&A section, again, in your WebEx dialog box. Looks like we do have just a couple, David.
Okay.
So first one we have is, can I use custom rules?
Yes. Custom rules, as I mentioned a couple of times, are enabled in the platform, and the rules are customizable for medical policies, but also for routing policies, or even rights and different level of security levels. Any kind of customization is possible. But if the question is about medical rules, yes, absolutely. You can create your own or import whatever standard is available.
All right, next one I have is, and I think I know the answer, but will it integrate with my portal?
Absolutely. We will actually help you integrate all the functionalities that I've presented to you today into your portal environment so that your users can use it. The interesting point is that we today have a good dozen frameworks that are already pre-built with I don't know how many reports. We have a lot of reports that you can pick and choose from. So it is never, it is extremely rarely a full build. We always reuse what has been put together and integrate into whatever environment is necessary. And that works from both sides. We've integrated into customer intranets, meaning payer intranets, as well as vendor portals and other provider environments for them to utilize the information that is exchanged on the platform.
All right. I have another question of how compliant do you believe payers will be on this utilizing?
Well, so it's a difficult question in the sense that we don't know exactly what the rules are yet. What we know is a lot of payers are extremely interested in talking to us about this particular transaction, and I think for two reasons. One is because of the compliance that are coming up, and we've seen with the core phase 1, 2, and 3 already that compliance is largely met by payers. The thing that we see, though, is that the 278 transaction, more so than the other ones, are bearing them a lot of savings that are motivating the payers, I would say, more than the eligibility transaction, for instance. So, depending on the complexity of the rule that is supposed to come soon, we should see a great interest in those transactions, and probably most of the payers are going to comply pretty fast. Oh, I've got another caveat. Depending on how ICD-10 works, if that is a big mess, then maybe there will be a chance that that particular mandate is pushed a little bit. But if ICD-10 goes fine, and seeing the interest that payers have for this transaction right now, we should be compliant.
All right. Well, I guess the next good question to ask would, when would we be able to start using this solution?
Right away. Give us a call and we'll figure it out.
Very good. and I guess to go along with that, will there be integration guides so that we can build it into our software?
Well, so yes, if you are a submitter, here's how it works. Our model is a payer-sponsored platform model, meaning that payers that are our customers, you saw a list at the beginning of the presentation, subscribe into the platform to make available to their provider community or submitter community the functionalities they desire. So if you take Cigna, for instance, if you were to work with Cigna, or if you have eligibility requests to submit to Cigna or claims to submit to Cigna, it is absolutely free of charge for you to do so through the post-and-track platform. So in the same manner, whatever the payer elects to subscribe to on the platform will be accessible to any submitter, including all the code for the API, the web services that will allow you to fully integrate into your environment. So same, give us a call and we'll be able to walk you through how that would work, which is already enabled for most of the other transactions.
All right, down to just our final couple ones here. Can I utilize the native EDI 278 transaction?
Yeah, absolutely, absolutely. The basic functionalities is transporting of EDI, and again, either you can connect to the platform through the API, an FTP connection, or utilizing the DoDat desktop and exchange native EDI and submit native EDI and receive native EDI directly from the platform. The user interfaces are optional means of communications or connections that submitters that cannot create those EDI transactions would utilize to be able to communicate with the payers. But if you can, absolutely.
All right, and the last one here. Do you update and use my prior authorization number format?
Yes, we can absolutely do that. We can link. Actually, I think I would like to have a little more information on the question. But if the intent is to, as a payer, the interest of working in automating the prior authorization format is to be able to link that to your claims process in the background down the line and make sure that any exchange that is subsequent to this prior authorization is actually kept in the records and linked for you so that you can find this particular number again, and if necessary, when the claim is submitted after that, you can update the prior authorization number and link it with the claim to actually improve the efficiency of your claim process. So I hope it answers the question, but it's really something that we find is an added value to enabling the automation of that prior authorization process.
Okay, we have a couple other questions that I think we need to do a little more research on, but we promise to get back to you after the webinar, and that will conclude our presentation for today. Again, this has been recorded, and we will make it available to all attendees. We thank you for your time and hope you found it beneficial. Have a great day.
Goodbye. Thank you.